We're going to start with documentation strategies for success, and we can do that too. All right. No problem. I can work with that. We have gigantic changes coming January 1st. So all those 1995 documentation guidelines, 4 HPI, 10 review of systems, 2 past family social history, they're all gone. I'm going to my 30th medical school reunion coming up, so you can do the math. It's this weekend. All the way, these are the only guidelines I've ever worked with. 1995, what was going on? Michael Jordan returned out of retirement, won the NBA MVP. Forrest Gump, Best Picture, and a gritty docudrama exposed the inner workings of a Chicago emergency department. It was a long time ago, and I just started medical school. For the last 25 years, we've had guidelines that were promulgated by Medicare, and then the AMA had to follow along. And if you went to the various Medicare administrative contractor websites, they had their own audit tools, and that's what everybody more or less, by industry standard, had to follow. Now it's completely changed. The AMA actually is leading this new effort. And again, January 1, 7 months from now, we will have brand new documentation guidelines. CMS, we will generally adopt the new coding, preparatory language, and interpretive guidance that has been issued by the AMA CPT, and we're going to follow their medical decision-making guidelines. So that's a bunch of words for folks that don't live in this space, but we're going to break it down into what will impact your practice 7 months from now. Quote, current CPT code changes allow clinicians to choose the office codes. The office codes changed 15 months ago, January 1st, 2021. So we've been working with this new construct of how records will be coded for about 15 months. How many are involved in urgent care in the room? Some, handful. So these are starting to trickle out, starting to generate some awareness. Here are 2 big changes. Number 1, requires performance of history and physical exam only as medically appropriate. So the history and exam, all that 4 HPI, 10 review of systems, it's all going away. The entire record will be scored by either medical decision-making or time. And then we're going to talk about time in the emergency department. This is right out of CPT. Time is not a descriptive component for emergency department levels of E&M service. Why? It would be impossible to keep track of time for an individual patient in an emergency department. Here's the CPT language. We're treating patients involving multiple encounters, several patients over an extended period of time with variable intensity. I run into room 3, the nurse says, hey, Mike, the patient in room 3 looks bad. I make a quick assessment, I go into room 7, reduce a nursemaid's elbow, we're single coverage, and I go into room 12 and dispo somebody who's been waiting for a little while and then circle back to room 3. Who could keep track of that time? And all the way back in the 90s, we convinced CPT that that was the case. So there's going to be brand new scoring, and nobody needs to become a coder in this room. All we need to know are the things that the coder is going to use to score our records. And why do we care about these E&M levels? 99281 through 99285, they make up over 80% of the RVUs, over 80% of the revenue generated by your department. And this is a little snippet of the type of grid that a coder is going to use. And they're going to go through our record and then go into the purple and white thing here and circle. Oh, we did a bunch of tests. Oh, there was an independent historian involved. Oh, we considered hospitalization of the COPD patient. Okay, great. So where do we stand now? We've got 2022 officer urgent care, history and exam, not scored at all. MDM or time determined the level. And those office codes have typical times, but the corresponding ED codes, 99281 through 99285, they do not have any typical times. The office codes have a brand new medical decision-making scoring grid, and those changes are now permanent. And I think this is the only set of guidelines that I'm going to have for the rest of my career. And there is a little bit of history in stating that because there were, for those who have been doing this for a long, long time, there was briefly a period of 1997 guidelines, but then they never really got traction. 1995 is what we've lived with. It's going away in the ED, almost certainly January 1st, and we're going to talk about how you can prepare between now and when they're implemented, and why it matters, which is 80% of your revenue comes from just these 5 codes. So as we sit here now, in May 2022, history and physical exam still required in the ED, but that's going to go away. History, physical exam, and some old medical decision-making rules that we won't even go into determine your level. And the medical decision-making isn't updated yet, and We've got a very engaged team working within the AMA, CPT, CMS, and the Relative Value Update Committee, tweaking those office guidelines so that they're more appropriate for the emergency department. So if we look at the office codes, the purple and white grid that I showed a snippet of, there are about half a dozen things that are immediately obvious that we can start to think about now. And what does that mean, start to think about? Start to think about how you're going to update the construct of your medical record. Number one, review of external notes. What's an external note? That is something that I review that did not come from a provider in my own group. It's nursing home notes, EMS notes, discharge summary. Use of an independent historian. And that's been clarified. We just had a terrific lecture about pediatrics, OBS, and flow. Parents are definitively allowed to be independent historians. And in the purple and white little grid, you get some points, and the coder goes in and circles that. So you want to use the word independent historian. Could be a guardian, could be a spouse. Independent interpretation of tests. You do not have to bill for the test in order to get points for the interpretation. EKG, chest x-ray, ankle x-ray. Some of us read our own CT scans. Head CT, abdominal CT. Some of us read our own ultrasounds. Some of us perform our own ultrasounds. Those independent interpretations have very significant value in determining, is it a 3, is it a 4, is it a 4, is it a 5? And then something brand new, decision regarding hospitalization. So I'm seeing the 18-month-old Wheezer, they get a round of nebs, they're slightly improved, the chest x-ray is negative, they've gotten steroids, I go back in, reassess, might fly, might not, might need OBS, might need inpatient criteria. Now I'm documenting that thought process, my decision regarding hospitalization, and that has a big impact in that purple and white little grid. And then another brand new concept, something that we've been doing cognitively for years now, but never got credit for. And this is why the role of the AMA and CPT in promulgating these new guidelines, this is one of the ways that it's favorable. Because it is a clinician-dominated organization, so things that clinically make sense, it's just as easy to write the prescription versus not write the prescription. The not writing the prescription, the not getting the head CT for the 2-year-old that met PCARN criteria, and you discuss with the mother, hey, I really don't think a CAT scan is indicated. That's a lot of work, and now that work is recognized. So testing considered, if not performed, the example is the head CT. Treatment considered, if not performed, that could be antivirals in today's day and age or antibiotics. And that received no recognition in the scoring of our records previously, and it receives significant recognition currently. So let's go through a couple of cases. On the left is the base case. Using the 2023 guidelines, the base case scores as a level 3. 14-year-old with temp 101, wet cough, COVID negative. Final diagnosis, bronchitis. We might see 10 of these a day during fever flu season, using all the tools. And we're going to go through these cases and then look at all the tools available. We came up with 6 to start with. That's based on digesting and distilling the current office guidelines. And then if I sort of use some intuition about what the final ED guidelines will look like, and they won't come out probably till late summer, early fall. But we've got to start our preparatory process now. History gathered from patient and independent historian, mother. I'm scoring some points in that little purple and white grid. Consideration of prescription for antiviral antibiotics. That's my SMART note, my dot phrase. Testing negative, patient looks well, lungs clear, discussed with mother, not indicated for additional treatment. 2023 guidelines, that now scores as a level 4. The work is the same, the cognitive process is the same, but we said the stuff that the coder needed to circle the little things on the purple and white grid. Level 4 versus level 3. Base case. Level 4 based on the 2023 guidelines for the office code on the left. 52-year-old male with COPD presents with wheezing and tachypnea, receives several rounds of nebs, CBC, Chem7, chest x-ray negative. Patient ultimately improves. Disposition, improved, discharge home with PCP follow-up. Okay, great. Seems like a well-documented record. Now let's use all the tools that are available to us within these new guidelines. Same clinical presentation, 52-year-old, COPD presents with wheezing, Chest x-ray, independent interpretation, the magic dot phrase. Chronic changes, no infiltrate. I reviewed the external notes, good clinical care. It's something that we all do on a regular basis. Most of the folks in this room have been mature users of an enterprise EHR for greater than 5 years, and many for greater than 7, 8, or even 10 years. The old records are almost always available. External note reviewed, prior admission, baseline O2 set 92%. Consideration regarding hospitalization. Patient reassessed, still with moderate wheeze. I discussed with the family, may require inpatient care. Now I'm going to reassess the patient. They're more comfortable. Wheezing is diminished, disposition improved, and discharge home. Using the 2023 guidelines, that case now scores as a level 5. It's all the work we were already doing, all the cognitive effort that was already taking place, but we use the words that the coders need to recognize that work and report it appropriately. Nobody needs to become a coder in this room. We just need to know the half a dozen to dozen things that the coders will be looking for. And the guidelines aren't fully baked yet. We've got a pretty good sense of what they're going to look like based on the office codes being around now for almost a year and a half. And we're going to really dive into the full menu shortly. 42-year-old male presents with vague chest pain for the last 3 weeks. He reports that it's worse if he coughs. Patient appears comfortable on my eval. D-dimer, cardiac profile are negative. I ordered basic labs, this is a real record, including lipase due to some vomiting after coughing, some post-tussive emesis, expiratory wheezing noted, given an inhaler treatment in the ED, rapid COVID test sent, and a chest x-ray taken. So now we're going to get some results back, follow up. EKG and chest x-ray normal, the D-dimer is negative, CMP is unremarkable, the troponin, the BNP are both normal, patient appears stable on the provider's reevaluation, the lungs are now clear after the NEB treatment, strict return precautions for any worsening, shortness of breath, chest pain, or any other symptoms. He got an albuterol treatment in the ED, and now we're going to let him take that inhaler home with him. All right? Nobody needs to be a coder. This is what the coder will look like to score this exact record. And we're going to walk through it at a very high level together because it's going to sensitize us to the things that we need to know. I need to meet 2 out of 3 of these columns in order to reach a given level. And I've got on the left the levels, level 4 versus level 5. And there are 3 components. There's problems, that's component 1, data, that's component 2, and risk, that's component 3. So I need to meet 2 out of 3 of those to support a given level. So everybody has that vignette in their head. It was basically a chest pain workup that got some nebs and ultimately went home. Well, do I have a bunch of data? I did a lot of tests. I did a D-dimer, troponin, BNP, basic labs, a chest x-ray, and an EKG. I met the data requirement there, and the patient got prescription drug management. They got an albuterol inhaler. So I've satisfied the requirements for a level 4. That's one way to look at this case. Here's another way to look at this case. I did a bunch of tests, D-dimer, troponin, BNP, basic labs, chest x-ray, but I had an independent interpretation of my EKG. Every single person in this room that ever orders an EKG performs an independent interpretation. And I had a discussion regarding the possible hospitalization of this chest pain patient. And now I've scored a level 5. And then for those who are like super paying attention, you might say, well, wait a second, in that left-hand column under problems, could you consider this a chronic illness or an acute problem that poses a threat to life or injury? You could, and I've made that argument successfully under audit, but that's squishy because this patient has cough, vague chest pain, wheeze, and vomiting. And yes, we can put our clinical hats on and win that under audit almost all the time, but that decision regarding hospitalization, if it's documented, it's black and white. Same cognitive effort, same clinical evaluation, and now we've got a level 5 instead of a level 4. And we deserve, and the work and complexity reflect, a level 5 evaluation. So let's go through some best practices. Now we've gone through 4 vignettes. We understand, okay, could be a 3, could be a 4, could be a 4, could be a 5. What do I need to document? We started with 6 ideas. Now we're going to expand to 11 ideas. Document appropriate consideration of admission. We saw that in 2 of the vignettes. Even if the patient's ultimately discharged. chest pain, COPD, asthma, hyperglycemia. That's always in our mind clinically as bedside providers. Document discussion of management with other providers. Every time a patient gets admitted, does anybody push the little Staples button and the patient zooms right upstairs? How many make 2 phone calls for an admission? How many make 3 phone calls for an admission? I got some more hands, right? So you're discussing plenty with other providers. And then it doesn't have to be the admitting team. It could be patients that go home. In fact, those are the ones where this component of the documentation probably has the most significant impact. You speak to a consultant, and together with some shared decision-making, we're all comfortable and the patient actually goes home. GI, neuro, primary care physician, could be social work. Documented differential diagnosis, chest pain, could be pneumothorax, GERD, ACS, if you're comfortable. How many in the room not comfortable traditionally documenting a differential diagnosis for medical legal concerns? Not too many in this audience. I've been doing it for a long time, my whole career. I have done expert witness work. I've never seen the differential actually cause a problem for a provider. We put out a differential. Don't put something squirrely in your differential like subarachnoid hemorrhage and not evaluate it at all, not get a head CT, not fully feel like you've ruled it out. Fine. And I'm not a medical legal expert, but I have 25 years of clinical experience and have done some expert witness work. Differential diagnosis does not generally cause problems. It's very, very uncommon. What causes medical legal issues? Unhappy patients and bad outcomes. And everybody here wants to be a good doctor. We're investing processes here, our time here, so that we can run the best departments possible, so that the right care is delivered at the right time. That's what decreases medical legal risk. Document your independent interpretation. Again, it does not have to be the same level of documentation if you are billing it. EKG, rhythm strip, plain x-ray, CAT scans, your own ultrasounds. Document review of external records. Inpatient hospital, office records, nursing home. The thing that doesn't count is your colleague's prior visit 3 days ago. That's not an external record. Document diagnostic tests appropriately considered, even if not performed. We went through the head CT example with PCARN criteria applied. Could be an x-ray, could be a CAT scan, and a discussion with the patient or family related to that. Prescription medications, even if they're not ultimately given. We see tons of people with viral syndromes, cough, cold, congestion. Right now, everybody's concerned with the slightest cough, cold, fever. We may or may not decide to treat it. Probably a year from now, we'll be giving Paxlovid like we give Tamiflu. It will be 18 months, but hopefully next flu season. Antibiotics, antivirals, pain medication. Document if history is obtained from an independent source, and that can be a parent. That's very clear. Caregiver, EMS. Chronic illnesses impacting care. You see a patient with cellulitis, they have diabetes, hypertension, they're cigarette smokers. You're going to think differently about that patient than if it's a regular, healthy 20-year-old who happened to have cut themselves while playing baseball. Document of care is affected by social determinants of health. This is brand new. Social determinants of health. That's homelessness, literacy, low education level, lack of access to medical care, problems with social services, and other psychological issues. You actually get points for that in the little purple and white, and it at times will be the definitive thing that changes the complexity of a case from a 3 to a 4. Social determinants of health. So that should be a pick list within your EPIC or Cerner Smart Note. Document discussion of test interpretation with external physician. This is, hey, the radiologist, it's Friday, 4 p.m. You see the surgeon going through the parking lot. It's a beautiful summer day, 4 p.m. She's going for a car, that's it. And you're like, well, I had the 19-year-old with right lower quadrant pain. That doc always makes us get a CT, so I got the CT. I'm pretty confident it's appendicitis. The CAT scan comes back just negative. And so you call the radiologist, say, you know, really the urine's normal. This patient really has progressed in their exam. It really feels like appendicitis to me. Is there any stranding maybe in the right lower quadrant? And the radiologist looks at him, you know, actually on image 39, there is some stranding. And then you call the surgeon who hopefully is just barely pulling out of the parking lot, and things work out well. That's a lot of cognitive effort on your part, and you score points for that. All right, we're going to wrap up with some silver linings to these guidelines. And in review, Everything is changing January 1st of 2023. 80% of our RVUs, 80% of the money that flows into your department is determined by the 5 codes, 99281 through 99285. The rules that govern the way those codes are assigned, brand new, no changes since 1995. So really sort of a paradigm shift, probably once in a career for most of us. Big, big change. We've got some silver linings. Prudent Layperson. Prudent Layperson Act is a national act that states, sort of consistent with the EMTALA definition, that reasonable people are allowed to have care covered by their insurance companies if they present with concerning complaints that they as a layperson are concerned about. I think that my earache that causes a headache could be a big problem for me. I'm going to the emergency department. I think my abdominal pain might be appendicitis. I sprained my ankle. I wonder if I have a fracture. I can't put any weight on it. Those are prudent layperson type cases, and it generally ties to the EMTALA definition. And many, many insurance companies are denying low-level visits based on the final diagnosis. So the patient, and as a bedside provider, we deal with the chief complaint, headache. Well, I've got a differential diagnosis for headache, and in a 62-year-old, it's pretty broad and has a lot of bad stuff. And what if the final diagnosis is toothache, or tooth pain, or dental caries? But I did labs and a head CT, and I even considered an LP, but then the exam got better, and the CAT scan's normal, and everything seems reasonable, and the patient's blood pressure came down. Fine. But the insurance companies, particularly managed Medicaid in your individual state, are using diagnosis edits to deny those visits. And we now have a silver lining to fight back. This is right out of the CPT book. That's the main Bible that's used when you argue about policy and cases. AMA CPT 2022. The final diagnosis for a condition does not in itself determine the complexity or risk. Extensive evaluation may be required to reach the conclusion that the signs or symptoms, the thing that we started with, do not represent a highly morbid condition. This is an enormous tool to fight managed Medicaid denials. Silver lining, impetigo, my BP is elevated. I came today because I twisted my ankle. Nobody sees this case, right? It's very common. Multiple problems of a lower severity may in the aggregate create higher risk due to their interaction. Diabetic, hypertension, mild cellulitis, lower extremity. I want a head CT right now, please, for my child. Ordering a test may include those considered but not selected after shared decision making. A patient may request diagnostic imaging, and the discussion of lack of benefit may be required. Document the considerations. And this is the actual language that is giving the coder the right to go into that purple and white thing and circle head CT considered. I considered the testing. I considered the antiviral. I considered the antibiotics. And that's a brand new process. So we've got some brand new documentation guidelines in 2023. History and physical exam only as medically required. Medical decision making will drive the code selection because we don't have time associated with our codes. There's a brand new MDM process. We don't know exactly what it is, but we've been living with the office codes for a year and a half. We went through a bunch of vignettes and came up with 11 things to take back to the shop and consider starting to work into our smart notes, starting to work into our chart construct. Focus on key provider documentation opportunities. And my contact information is here. I receive inbound email questions from folks throughout the country on a regular basis. Totally happy to answer literally anybody's question in this room. I just ask that you give a little bit of context. Hey, Mike, I was at the ED Innovation Conference in New Orleans. Wasn't that great? And I have a follow-up question. Thanks very much.
Thank you so much.